Hello, good afternoon all, and welcome to the Hounslow Health and Wellbeing Board. I'm Councillor Lily Bath. I'm the Cabinet Member for Adult Social Care, Public Health, Health and Social Care Integration, and I chair this board. I'm going to go around and ask everybody very quickly to introduce themselves. I'd also actually like to welcome all those that are joining in online as well. Thank you. So if I start to my left.
Thank you, Councillor Bath. Kelly O'Neill, Director of Public Health.
Thanks, Kelly. Astha from Health Coach Hounslow. I'm the Operations and Research Manager.
Carleen Duffy, I'm the Health Watch Area Manager.
Councillor Sue Sampson, Lead Member for Housing and Homelessness.
Mother Stanica, Director of Housing.
Pauline Jones, Service Manager for Rough Sleeping and Hospital Discharge.
Bhavana Ailu, Senior Public Health Strategist for Health Improvement.
Chris Hilton, I'm the Chief Operating Officer for West London Trust, covering mental health and community services.
Hi, Dr. Amit Gupta, Hounslow Borough Medical Director and Primary Care Representative.
And I'm Stephen Forbes, I'm Executive Director for Children's and Adult Services here at the Council.
Jane Medici, I'm the... Where am I today? Health and Wellbeing Board clerk today. Thank you.
Thank you. I'll remind you when you forget where you are. Can I also take any apologies? Do we have apologies?
Yes.
Yep.
We've got Peter Golding and Martin is away as well.
Thank you. So that's 2 apologies. Before we start, can I just remind you to just remember to declare an interest if there are any. I'm assuming there's no declarations of interest. Is that correct? Okay, excellent. Thank you. So in that case, we'll move on to the next item on the agenda. And I chair this meeting, but we also require a vice chair of the board. So what I would like to do is to propose Councillor Sue Sampson, who's here today. She's a cabinet member for housing. So what I would like to do is propose her as the vice chair of this board. So I would need someone to second that.
Councillor Bath, I'm happy to second that.
Lovely. In that case, is everybody in agreement with that? Yep. Okay. So we duly elected Councillor Sue Sampson as the Vice Chair of the Health and Wellbeing Board. Thank you. We will now then move on to minutes of the last meeting, which were held on the 17th of July. And what I intend to do is just really go through minutes and any matters arising that are not sort of on the agenda together, if that's okay. Page 7. It's on the agenda. Oh yes. Okay. Yeah. The only thing on the agenda is we've got a presentation which is actually going to be presented by Dr. Amit Gupta and Chris today. Okay. Page 8. Page 9. Page 10. Nope. Page 11, 12, 13, 14. So can I just confirm that the minutes is an accurate record and no matters arising? Thank you very much. Okie dokie. Then we're moving on very swiftly to the next item on the agenda, which is health and wellbeing updates. And Councillor Sue Sampson is needs to leave early because she's got another meeting, and she would like to contribute to. There's an item on the agenda around homelessness, and she would like to be part of that while the discussion takes place. So if we can flip it, so we got Pauline first. Is that okay with you? Yeah, perfect. Thank you very much, Pauline. So over to you. And this is
Fantastic.
around the health and wellbeing project updates. Thank you.
Thank you, Councillor Bath. My name is Pauline. I'm the Service Manager for Rough Sleeping and Partnerships. So I oversee the rough sleeping team and the hospital discharge team. Earlier in the year, we conducted an audit of all rough sleepers in temporary accommodation. The aim of this was to look at move-on plans, identify who had rent accounts and set up rent accounts and identify who is engaging. Out of the 50 rough sleepers in temporary accommodation, it was identified that 14 people were NRPF, so no recourse to public funds, and not eligible for housing assistance. This meant that they could not claim housing benefits, and moving them on unless they were working, had the right to rent, was going to be very challenging. These individuals had been placed under an employment offer, the aim of which was to get those with no recourse work ready and move them on into private rented accommodation before they secured their settled status. It was clear, however, that at least half of the residents were unable to work for a variety of reasons, including poor health, alcohol and drug issues. Often we find this is the case when we bring people in off the streets and into accommodation. Needs that were not apparent when they were on the streets are more noticeable and lead to the need for further investigation and support. Since funding for rough sleepers with no recourse public funds had come to an end in August 2020, continuing to place and fund these placements was eating significantly into our budget. All residents had been referred to North Kensington Law Centre for specialist immigration support. However, the process is often slow due to challenges obtaining documents to prove residency in the UK, high caseloads at the law centre and delays at the Home Office. We conducted risk assessments on each individual and identified those who were the most vulnerable and those who needed care, who had care and support needs. We then made referrals to adult social care for those individuals. We will look at the outcomes for those in a minute. The aim was to move everybody out of temporary accommodation by the end of August 2024. So the Q1 risks were those 14 individuals potentially having to return to the streets for the reasons that I've just given. The outcomes have been a lot more positive than we expected, and that's a credit to the team and to the clients who have engaged effectively to find a long-term route off the streets. So 4 people secured their settled status under the EUSS, 3 people moved into alternative accommodation, 2 people remain in temporary accommodation pending adult social care referrals. 1 person was accommodated by Ealing Adult Social Care. 1 person started work. 2 people are still in temporary accommodation pending Home Office decisions. We actually got the news today that one of them's now secured their settled status. So we're now able to claim benefits and remain in temporary accommodation. And 1 person left and returned to the streets. So out of 14, 1 person the accommodation was terminated, and that individual has returned to rough sleeping. So like I said, the outcomes have been a lot more positive than we expected, and a lot more positive than they were in Q1. We're now in Q3. So we're still waiting to see if we can secure additional support for the 2 individuals that have had our adult social care referrals, and we'll focus on those individuals in a second. So the challenge is now that we face that those on the streets and our inability to place people that have got no recourse to public funds. We've seen an increase in rough sleeping over the last 12 months. And we currently have 24 people experiencing rough sleeping who have no recourse to public funds. We can offer welfare checks and we can offer immigration support. We can signpost them. But unless they are placed under severe weather protocol, we cannot accommodate them until they're eligible for housing assistance. So I just want to look at some of the reasons for people rough sleeping. So obviously sorry, my apologies. So obviously there are a number of factors that lead to people rough sleeping: poverty, inequality, housing supply and affordability, unemployment or insecure employment. And that's something we see particularly with the no recourse cohort. You know, they're in accommodation they're in work that's cash in hand. They don't have a worker history via PAYE, and they don't have access to welfare benefits. Quite often they have poor physical health, mental health issues, and obviously they're all exacerbated by remaining on the streets. Unfortunately, the health life expectancy and the life expectancy of rough sleepers is a lot lower than the average person. The life expectancy of a female rough sleeper is 43 and a male rough sleeper is 47, so it's significantly lower than you or I. There is a high likelihood of them dying from injury, poisoning and suicide, and it's estimated that around 35% of people who die whilst rough sleeping die due to alcohol or drugs, compared to the 2% in the general population. So that's a significant difference. So obviously very concerned for this cohort, these 24 gentlemen actually at the moment that are out rough sleeping that have got no recourse to public funds. So we're kind of looking at the poor health outcomes that are increased, the exposure to poor living conditions, their inability to maintain their personal hygiene, poor diet due to having no recourse to public funds, being unable to cook, high levels of stress due to being out on the streets and the associated factors with that, and drug and alcohol dependency. So the rough sleeping strategy that was published initially in 2018 focused on prevent, intervene and recover and prevent. Unfortunately for this particular cohort, we are not able to intervene where we want to intervene because we're not able to offer accommodation. And obviously housing quite often is the foundation to be able to then build upon addressing some of those issues. So this cohort are at significant risk of dying, particularly if we have harsh winters. They're an ageing population of rough sleepers. And this particularly highlights the importance of working together to better support these individuals, that despite their circumstances, they're still able to access the right care and support they need, that we can try and mitigate the risk of them dying on the streets by providing somewhere safe to stay, regardless of their immigration status. I think a greater understanding of the cohort and potential risk is needed, and the levels of health and social care provision to support them needs to be increased. Conversely, we in housing would benefit from understanding the limitations of other services. We would benefit from a mapping exercise to identify what is available for this vulnerable cohort across services, to identify the gaps and inform future commissioning. We know that it is likely the government will push for greater co-production of services delivered using a multi-agency approach, and to enable us to submit proposals for future funding opportunities, we need to be prepared. So initially, the focus and the reason for the reg rating was because we had these 14 individuals. Thankfully, we're down to kind of 4, 2 of which were waiting for the outcome of the adult social care referrals, and the other 2 we were waiting for immigration status, and obviously one of those has now secured that. So, you know, the outcomes were not as bad as initially predicted, but the ongoing concern of how we support this cohort is still there. Thank you for your time.
Thank you, Pauline. That was very interesting. So some good outcomes in terms of actually reducing the cohort, but obviously a massive challenge. And I was just reading the case studies, and they are sort of really, I mean, they're not surprising, but it's quite sobering, just reminds you of what the challenges are. So in terms of going forward, I've seen some of the recommendations. Are you suggesting that you'll be doing more mapping exercises? Is that what's going to happen going forward?
I think we probably need to. You know, we've seen over the last couple of years kind of the rough sleeper grant, the OHID grant. So I think kind of moving forward, the likelihood is that MHCLG will be expecting us to share funding with other directorates. So I think probably now is the good time, with the spending review coming up next week, to start doing some of that mapping around the services that are available, particularly for this cohort, and also for those that are no recourse public funds.
Because I noticed somewhere in your report, you mentioned getting immigration advice, but going outside of the borough. I'm assuming that's because it doesn't exist here.
Yeah, so that's sub-regional funding. It's pan-London sub-regional funding. So, and unfortunately, that comes to an end in March 2025 when RSI funding comes to an end. And at the moment, none of us know what's happening after March 2025. I mean, we're hoping for 12 months bridging funding, but at the moment we just don't know. We'll see what next week brings.
Okay, thank you.
Thank you.
Can I take Kelly? Yeah.
Thanks, Pauline, for that. Just to pick up on just a number of queries. In the performance report for the health and wellbeing strategy, it is rated red. I suppose, given the things that the comments that you've made and the fact that we're always going to have a small group of people who are not going to have a warm, affordable home, and particularly in that kind of that performance indicator.
Yeah.
I suppose my question becomes to you, well, how do we measure that? Because otherwise it's just red all the time. And I
Yeah.
kind of wonder what your service sees as a success criteria. So that's number one. The second point is you talk about what other services are available. And I think you already work with Claire and Richard from
Yeah.
Public Health, because obviously as a public health team responsible for the commissioning of drug and alcohol services. And we also have an inclusion health team. And as part of the new, well, it's not new, that we're in the third year of the new substance misuse grant, there is a requirement for a panel for drug-related deaths. And what we do know is that suicide prevention learning panels and the drug-related death panel will be exactly what you said, proportionately sort of over, the numbers of people who are going to be in your cohort are likely to be disproportionately high compared to the general population. I kind of wonder how we just link all of that work together so that we come up with some meaningful learning and then take action. And I suppose just looking at Chris, that group will have the kind of triangulation of relationship breakdown, homelessness, and rough sleeping and mental health. So within this room, there's probably an opportunity to help support that work as part of an inclusion health program. So I'm kind of asking you to link into that as an opportunity just to make sure that you're getting the best out of those services that are being commissioned by other services. I suppose the next question is, and you don't have to answer now, is what does success look like for the service? Because otherwise, I think we may be over-expecting something that's quite unrealistic. And I thought the third one is, Chris, in terms of the mental health provision for that particular group, what are we currently doing and what else could we be doing, recognising that it's a cohort that sometimes is quite difficult to reach, but not unreachable?
Thank you, Kelly. Chris, did you want to come in? I can see your hand.
I just wondered if it would be helpful for me to come back on the last point first, around mental health support. And I'd be certainly interested in Pauline's perspective on your experiences of accessing support for the rough sleeping population and the people who don't have stable homes population. My understanding of the services that are available in Hounslow through my own organisation is that we have the RAMP team, the mental health team that provides assertive support for individuals who are rough sleeping, and I think should be working closely with your team to support individuals into more stable living arrangements, and also to provide intensive mental health support. And my experience of them, including shadowing them, is that they are pretty assertive in their approach. One of the challenges that we then find is, as they were commissioned for people who are street homeless, when individuals then do transition into temporary accommodation, they then start to access mainstream mental health services, where the assertiveness is less, it's harder for them to be assertive because of the wider caseloads. But I'd be really interested in your feedback and learning about what more we can do to support that population.
Absolutely. I mean, firstly, the work that RAMP does is absolutely fantastic. I think most boroughs in London have now got a RAMP team, and I think the outcomes have been really, really positive. But Chris is right. Once they move into accommodation, that's generally where it tends to fall down. So amazing work that RAMP are doing. I think the success of RAMP is that they are a flexible service. So rather than being a linear model like the traditional models of support, they go out to the rough sleepers, and I think that's probably what we need to see with other services. So kind of that outside of the box thinking, that kind of more flexible kind of holistic approach to rough sleepers is probably what's needed. And I think that's one of the challenges that we found even with adult social care. We can't assess them unless they're in accommodation, yet we can't bring them into accommodation. So, you know, at what point do we get them assessed? Can we bring them into Hounslow House? Can we bring them somewhere else? Can you come out onto the streets and assess them? So, yeah, I mean, I do think the work that's going on with rough sleepers and mental health is fantastic. The other two questions, Kelly,
Pauline, I can reach out to you and have a conversation.
Thank you.
I mean, we're at the end, we are going to start looking at some of the kind of indicators that we've got in the performance report. And I suppose it is a bit of a check-in to see, are we being realistic here? Because I think some of the way that we've worded it assumes that everyone's going to get a warm and affordable home. And actually that's not realistic.
Absolutely.
But actually what you've explained today helps us understand what the challenges are. But really, it is really important that we all get involved in tackling and supporting that, so that we can make some inroads into improving that performance indicator, because obviously it's not just a performance indicator, it's the people that sit behind it that's key.
Thank you.
Kelly,
Yeah, go ahead.
thank you, Councillor Bett. Just to say that is a very timely discussion, because we've just started looking at the refresh of the rough sleeping and homelessness strategy. So there is a working group that is meeting. We're going to start the internal engagement around November time with a view to have a draft strategy going to Cabinet. It's on the forward plan for April, then get authority from Cabinet to then go and do a wider consultation once we have something. But we're doing early engagement with partners. So Pauline will be touching base with everybody to sort of understand what needs to go in as the key priorities and how we bridge some of those gaps. And as you said, Kelly, everybody's not going to get a home, because we can't give everybody a home, because we're not allowed by law to give everybody a home. So if that is the success measure, then we need to change it. It's sort of saying that we are proactively working with all the partners and all the agencies and doing everything we can to try and minimize, people dying on the street and do every other thing aside from a home. If we can find shelters for people, that doesn't mean permanent accommodation. Similar to if there's an opportunity to provide the kind of things we do during this SWEP for people, shelters and stuff, then that to me is a success, not a permanent home. Thank you.
No, thank you. That's a good point. Yeah, got to be realistic about not being able to provide accommodation. I've also got, I think Stephen wanted to come in as well, and then I'll bring you in, Kelly. Is that okay? Yeah.
So just two things. Pauline, you and I need to have a conversation about assessment for adult social care, because assessment for adult social care is not subject to accommodation. So maybe you and Richard Brown, our service manager, just need a quick catch up outside of here, so we can just clarify that. What does worry me a wee bit, and maybe it's because I've just read the numbers wrong, but on the first slide you've got 14 no recourse to public funds people. So we've taken it down from 14 to 3 or 4, but that looks like we're about to have another 14 join the cohort because they're not eligible for housing.
No, so 4 of them secured their settled status, which means they're now eligible. 3 moved into alternative accommodation, so they secured their settled status and moved on into alternative accommodation. 1 person started work and is now able to claim benefits. And so really the 2 risks are the 2 that are in temporary accommodation that we've done the adult social care referrals for. They're the 2 that are potentially going to return to the streets.
How is the one that's in work managing to claim benefits if he's got
Because
no
he got
recourse
work
to
state, he's managed to get work, he's secured worker status.
Right. Okay. So then probably you've taken out my anxiety about the 14, but the question would be then is, are we seeing those with no recourse to public funds being the main cohort within homelessness, or do we anticipate that going forward?
Yeah, I mean, if we look at our current numbers, so I think our current numbers are 35, 24 of those have got no recourse to public funds. So yeah, still a significant portion of the cohort.
And how many of those might have been former asylum seekers, do we know?
So the NAS numbers are slowly increasing, probably about 5 at the moment.
I'm not going to ask another question. Question by tiny question by tiny question. I think probably in terms of what you said, Modesta, then about the strategy, we need to see that as a fundamental factor, because that does worry me slightly, that that's a driver. So we probably
So we
need a
need to do a little bit
conversation.
of cross-working here. I detect, yeah, okay. But from what you're saying is that the proportion of them are, sorry, what's the word? I've gone blank. No recourse to public funds, yeah, yeah. And I'm presuming that is the average according to each area. I know the silly question, really, it can vary, can't it, depending on
It
area.
probably is the average at the moment, to be honest, across London. Yeah. And I think everybody's seen an increase in those that have left NAS accommodation, the asylum seekers, and also those that just haven't applied under the EUSS, so haven't got settled status, aren't working, and are not eligible for benefits. So kind of the Eastern European cohort is continuing to increase.
So a quick question. I don't know if you would know this, but do you know just proportional, just average, how many that are no recourse to public funds actually end up having settled status? Do you know? Is it? I'm just curious.
Yeah, no, it's pretty high. It is pretty high, but they've got to access the support. So if then a lot of them are not willing to engage with it, and we even see those that have got their settled status that are still choosing to rough sleep because they don't want to pay for rent, don't want to pay for gas or electric. It's too expensive. So the cost of living has impacted on that as well.
Okay, thank you. I'm going to bring Kelly in quickly. Yeah.
Yep. Thank you. Just picking up on Stephen's point was my point. He stole my thunder a little bit. I think there's quite a few people around the table that we're really interested in engaging in the work on the homelessness and rough sleepers strategy. I definitely know that my colleagues in public health will be wanting to roll their sleeves up and help with that. But I think just really important, just with that new grant requirements for a drug-related deaths panel and linked to the suicide learning panel, it will be really good to just think about how do we bring that together so that the services that are built up around that, those particular areas, recognise that disproportionality and are able to focus a little bit more on your group. Is that right?
So I promised I wasn't going to ask another tiny question. But if I don't ask it, I'll forget it, and that's the key thing. Have you repatriated anybody who's got no recourse to public funds?
So we have managed to reconnect a few people back to home countries, a couple to Europe, and one back to Malaysia, two back to Malaysia, I think. So that's positive, and the offer is there. There's a service, a Pan London service that funds that, and we obviously, as a local authority, would look at kind of a resettlement package if people wanted to return home. The problem is very few people do.
Okay, you're thinking there. Yeah. 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 So obviously there's lots of work to be done. And thank you for the work that you've already done. I can't see, I think we've had a discussion. I think you've got to go off, haven't you, from the sounds of it. So we'll let you go unless anybody's got any urgent questions, but obviously we'll come back. We'll be feeding into the draft strategy, Modesta, definitely. Okay, thank you very much. Yep. Shall we then go to the second part? And over to you, Bhavna.
Thank you very much. I think I'm just waiting for the clicker. Thank you, Martha. Thank you. Good evening, everybody. So I'm here to provide an update on tobacco control to the Health and Wellbeing Board. Just looking at some of data, which is newly published by NHS Digital. So previously in 2023, it seemed as though we had a huge spike on population who are smokers in Hounslow. That has reduced to 13. For some reason, it has reduced to 13. So it was 16, but it's reduced to 13.4 now. Unfortunately, this data is a little bit unreliable because it's self-reported. It's an adult population survey. So I think we take it with a little bit of pinch of salt when we look at national data. Again, it's very small, but hopefully you can see that in your documents. We have sort of come down in the ranking for smoking in London. So we were in the top last year. Again, because of the data, we have now come down in the ranking, which is good news for us. Smoking cuts across all of our core 20 plus programs. So maternity, mental health, hypertension, cancer, as well. So it's an important part of the work that we do in public health. And this is GP registered data. This is our core 20 data. So if again, apologies that it's a little bit small, but you can see that smoking is quite prevalent in the borough. We have just over 36,000 smokers registered with GPs in the borough, and it almost sort of is the same as the hypertension. So if you know the correlation between hypertension and smoking, you can understand that a lot of them with hypertension probably do smoke as well. And this shows the deprivation status. So core 20 residents who are in these areas are usually higher, have higher rates of smokers compared to the rest of the population. So those who are smokers also live in more deprived areas in the borough, and increased health inequalities. So some of the efforts that we are taking in the borough for looking after tobacco control and making sure that we serve the population to improve stopping smoking, but also a wider tobacco program. We have a tobacco control alliance with different stakeholders from West London Trust, Chelsea and Westminster, NHS Trust, and our provided commission service, Healthy Hounslow, school nurses, and also health visiting service. So it's a wide range of stakeholders who are working to improve smoking, but also tobacco control efforts in the borough. We have the provision of stop smoking service. So we were one of the councils who kept our stop smoking service for a very long number of years, and recently with the stop smoking grant, new services are coming up in the neighbouring borough. So we usually used to get a lot of Ealing residents coming into our service because no one had provisions for local service. So we have a long-standing service, but we refreshed our service and we commissioned a new service which has got better evidence-based behavioural support service that will support people between 6 to 12 weeks of quitting smoking. We also received Swap to Stop from OHID, which means every adult who are stopping smoking is eligible to get 8 weeks of e-cigarettes for free. And that doesn't mean whether we also provide NRT. So with NRT, which is a quit smoking tool, it's a pharmacotherapy. Those who are not eligible for prescription will have to pay, whereas with the e-cigarettes, everybody gets it for free. So that's a good effort to provide in the borough. We work with planning, licensing, trading standards and enforcement to ensure all the tobacco coming into the borough is lawfully permitted. We have targeted lung health checks, which is being delivered in the borough. and that means that anyone who has been a long-time smoker will be screened to ensure that they get a lung health check, and also hopefully early diagnosis to show if there are any sort of conditions for lung health going forward. So the other thing that we always do is take a population health management approach to our tobacco control work and make sure that it's data driven, targeting our health inequalities. As we saw earlier, deprivation is linked to smoking. So we use our sort of core 20 locations to do a lot of outreach and reach those population. We have, through Healthy Hounslow, we have an Healthy Hounslow cardiovascular outreach program that does NHS health checks, but also blood pressure. So they go out to these communities offering full NHS health checks. Through that, we pick up lots of smokers and refer them into the smoking program. So this is what we provide currently, and it's on the website if anyone wants to visit. It's called Healthy Hounslow, and it's provided by one of our Healthy Hounslow Alliance provider, More Life. And its behavioral support is face-to-face clinics, virtual support, and it, according to their need, it is 6 to 12 weeks that they get support. Our current provision is we have 3 face-to-face clinics, but going forward, we would want to increase more of the face-to-face clinics as well. And we do have 7 smoking advisors. And since we received the smoke-free grant, we have increased this provision. So we used to have 5, now we have 7 to manage the demand and achieve our targets. So what we are currently doing is increasing our referrals into the service. One of the things that we are providing is rewards for people stopping smoking. And we are doing a lot of promotion around Stoptober. Hopefully you've seen some Stoptober campaign adverts out in the community. And we use Better Points. Better Points is a rewards app for anyone living in the borough. They can download this for free. And if you're a smoker, you will get £50 £50 of voucher if you quit smoking at the end of 4 weeks. We are looking at paying primary care for referral for very brief advice and onward referral to Healthy Hounslow. And there's a lot of events at the moment through Stoptober outreach. So you can see some of the events that we have going on. We are also, we're also doing a lot of training in terms of referring into the program. So sometimes people find it hard to talk about stopping smoking. So for all those professionals and stakeholders, we provide very brief advice training for free. Illicit tobacco is another program that we work quite closely with and we fund. We have quite a prominent area of illicit tobacco working in the borough. Illicit tobacco can come from smokeless tobacco, smoking tobacco, vapes, and shisha. So it's not just cigarettes, but it comes in different forms as well. The sniffer dogs that we employ, well, we work with them to sniff out the illicit tobacco in the operation. You can see how much they save the council in terms of illicit tobacco going into the community as well. So we do work quite closely with them. It takes a lot of effort to gather intelligence and making sure that we understand the operation well, because I think it's coordinated between lots of different organizations. So it's a whole system partnership approach to tobacco control. We work with all different stakeholders. What we have here is the current activity under our tobacco control plan, where we want to gain a little bit more formalized working relationship is the discharge from our hospitals into the community. We know there's tobacco dependency program running in the hospitals, but what we haven't done is formalize the discharge into our community service. So making sure that people who go in to inpatients having that pathway into our service. The other thing that we are working with is the pediatric inpatient unit. So with the consultant there is giving them the discharge referral in for the parents. So discharge referral into Healthy Hounslow. That's one of the things that the consultant mentioned, that they have a lot of parents who smoke, and the children who attend inpatient have high levels of respiratory conditions because of that. So it's an important piece of work that we are running along with. The next steps that we are thinking of looking at is to continue the efforts that we are currently doing. We're refreshing our tobacco control plan. We're doing a needs assessment, so really understanding our needs within the borough. What are we currently doing? What are the gaps that we have? Where are the important areas that we need to focus on? So that will give us a plan for the next 3 years. And then it's the formalizing the partnerships between secondary acute care, maternity, and Healthy Hounslow. Thank you.
Thank you very much. So it's good to see that Hounslow's going down on the list. We're not right at the top. But yeah, obviously more way to go. Can I just ask you before I take questions? Obviously, lots of interesting stuff going on, lots of outreach, etc. And I know you have lots of interventions and activities, etc. But is there anything particularly that we're hearing back from residents or people that be part of the program that is really working for them, or is it just a?
I think what works for them is if somebody within their network quit smoking with the Stop Smoking service, they find that recommendation works much better. They do appreciate the support that they get, the behavior support, because it takes up to I think it takes up to 8 times to actually successfully quit. You will quit and then you'll relapse and you quit and relapse. So we do a lot of harm reduction. So they might not quit straight away, but they might reduce some of the quitting attempts, smoking throughout their quitting attempt. So whilst we may not have huge number of quitters, we still do a lot of harm reduction work with them.
I've got questions. I'll bring you questions. Christopher and then Kelly.
Thanks. I thought that was a great presentation. For one quick point about the Ealing
Yes.
overspill that you've been experiencing, that you can now redirect them back to Ealing, because we now have a commissioned service and West London is providing it. The second thing, I was just going to challenge you on your last slide, links to acute and I think it was maternity. Can I offer that we also try and expand some of those links into the community health pathways, the mental health pathways as well, particularly for respiratory, the universal children's services where parents are maybe smokers, and lots of other pathways. We know that in Hounslow, between a quarter and a third of mental health patients say that they smoke. And we do have some specific targeted interventions for that population through the Trust's Healthy Lifestyles practitioners. So any way we can make more visible that work alongside your other contractor, I'd be really keen to have that discussion.
Yes, definitely. I would be really keen. We used to with HRCH, and we kind of lost a little bit of connection there. So it'd be really good to make that connection back. Thank you.
Thank you for offering that. Kelly?
Thanks, Bhavana. A couple of points just to sort of flag is that for those people who've been around a long time, if you kind of remember back to Strategic Health Authorities 20 years ago, stop smoking was, and I think hospital-acquired infection were the two things that anybody ever talked about the currency of the health service. And one of the things that, And one of the things that's really clear now is that real focus over a sustained period of time means that this 36,000 are really difficult, because if they were easy, would have got them to a kind of a healthier behaviour much earlier. So I think it'd be quite interesting to understand how many of those are new to smoking. And I know that we've had concerns about the number of children who are using vape, and we don't really have data about whether that's really a gateway to smoking or it is vaping. And equally, vaping is a harm reduction for those smoking, but it's not something that we would encourage as
For
if
under
you do
18,
not
yeah.
smoke. Yeah.
Yeah.
So I think that, one of the things that focus of smoking until quite recently, with the sort of the significant increase in the amount of money that's associated with the new strategy. Obviously, this is year one. That really sort of importance of making every contact count and how we can all play a role in this, given that it is the single most important determinant of health disparity of anything that we do. So I just wonder, and just to my colleagues as well, is that, I wonder how much we are making every contact count, how much we are putting in place arrangements that already exist, particularly around smoking on NHS sites. And again, that is an area where there has been a requirement not for NHS sites and some of our local authority sites to be not smoking, but you'll still see people connected to, kind of oxygen sitting outside hospitals having a smoke. And I think that, how do we support that? And again, that's a question for us all. But also just in terms of that lung check, because that lung check is a really, for want of a better phrase, a healthy intervention for an anytime smoker. And I know that we're new to that, so we haven't got the data, but we do have neighbouring boroughs in northwest London who've had this arrangement in place for 3 years. And what we see is a really low uptake for people. It's a really good intervention. And I kind of wonder how, through our different local services, we can make uptake meaningful, especially as we now have that service within the borough, which we didn't have before, particularly around GP colleagues. Looking at you, Amit.
Yeah, thank you, Kelly. So as you say, the targeted lung health checks has come to Hounslow. I think all the GP practices have now, all the GP practices have signed up. So the invitations go out from the service, and so we are getting, as you say, the data is early, but what's also being picked up from the targeted lung health checks, as well as the intended lung cancer, is evidence of cardiovascular disease around the heart. So actually that's indirectly also increasing the number of cardiovascular risk assessments that are going on as well. So it's sort of like, as you say, it's that picture. In terms of stop smoking, to provide some assurance, so anybody who's coded to be a smoker or an ex-smoker has to have their smoking status rechecked by their primary care service every year. And even if you have quit, we still offer you advice on the benefits of having quitted, in that it's one of the most positive, well, not one of the most, probably the most positive thing that you can do for your health to maintain that status. What was quite nice with Bhavana's team is that, as she mentioned, she sort of incentivized general practice to make referrals for stop smoking. However, there's a structured quit smoking assessment as part of that. As you said, Kelly, the remaining smokers are not the easy ones. And so we want to get those who are the most likely to consider quitting to go into services. And so it's not just a refer anybody that comes to you. You do a structured quit smoking assessment, and you refer those who are more ready to quit smoking. So there's always more can be done, but I think we've got some reasonable structure. But again, also happy to meet with colleagues if there's more that can be offered by primary care. Thanks.
Sorry, I didn't have my phone. Can I just ask a quick question, Bhavana? Earlier on, you said 36,000 were registered. Is that what's the population in terms of smokers? Those are the ones that have just registered and have engaged, but doing any more?
They're the ones registered as a smoker in the GP system. So we collect data from the GP system. So we know that 36,000, just over 36,000 have said that they are smokers. There are probably quite a lot more in the population. So it's 13.4% of our population. So I can't do the maths. unfortunately, but it's a lot more who haven't declared that they're a smoker. So
So
yes.
there's a lot more work to do
Yes.
around that bit. Okay.
Yes, so we do. That's why we do a lot of outreach, referrals with other stakeholders. So we work a lot with our Lambton Leisure. So anyone who comes through our Lambton Leisure, we make sure that every contact counts, like Kelly said. So we are offering every contact count training to I think we recently did 60 people were trained just in October, September, October, to talk about very brief advice to help with quitting smoking.
Okay, thank you very much. So if I have no further questions, this was just to note the all the activity that's taking place in this, and thank you very much. Obviously, there's a lot more to do, but it's good to see that some of the outcomes. Sorry? Oh, yes. Yeah. Kelly just reminded me that they were the red areas on the strategy. Yes. Okay. Thank you very much. If there's no further questions, I think we'll then move on. And we have agenda item 5, which is going to be Christopher. Yeah, because obviously Dominic's not here, and you're going to talk about high intensity uses. I know you've got an item afterwards, so you don't propose to focus too much on it, but I'll let you.
Thank you, Chair. And I picked up this with Dominic at a previous Health and Wellbeing Board meeting, because I think the board was interested in the work that's going on around so-called high-intensity users of health services in the borough of Hounslow. And just to be clear, in terms of navigation, there is a brief note paper regarding this item, which is actually attached to item 6 of the pack. So you'll see that I wasn't going to present any additional data, but I wanted to outline some of the work that has gone on and is still going on to the board to support this population. We know that about 0.6% of the population are defined as high intensity users of urgent and emergency care services. And just to acknowledge, the paper has been prepared here by my colleague, Dr. Omar Mahmood and Tom Heffernan, and it has rather a number of acronyms, which I'll try to spell out as I talk through. So apologies from us collectively for that. That very small percentage of high intensity users accounts for about 16% of emergency attendances in the UK, a third of ambulance attendances, and about a quarter of hospital admissions, with a significant cost to the NHS. And we have a group of high intensity users who attend defined as moderately frequently, and that means they're less than 20 times a year, but obviously that's more than 2 times a month for most months. And that's accounting for the majority of the attendances that we would define as high intensity users. And those who are high intensity users tend to remain frequent users of emergency services. We've done work on this for about a decade in Northwest London and in Hounslow in particular. And I've just wanted to think back to when I was personally involved as a clinician in some of this work back in before COVID. We did an audit of a significant number of high intensity users to West Middlesex Hospital. And we found a number of themes. So a lot of people were using services regularly because they had complex needs. And one of the factors that was driving high intensity use was that each attendance didn't address the fundamental needs that was triggering their attendance. Might be superficially responding to an immediate concern, but fundamentally not changing the underlying pattern of behavior. There was a cohort of patients who were known to mental health services. There were also individuals with substance misuse and alcohol needs. And there was a proportion of individuals who were in a frailty syndrome and perhaps in the last phase of life, and their frequency of attendance related to increasing physical frailty as they moved into the last phase of life. We also identified that we could care plan for these individuals, and that actually made really positive impact on reducing their attendances. And a lot of that relied on joint work between secondary care, primary care, and also other agencies, including the local authority, to try and identify the individuals, but also ensure that all of their needs were being addressed. So I've included in the note that's attached in the pack some information for Northwest London. So in 2018-19, we had 6,300 people who presented more than 10 times at emergency departments. And again, they accounted for 10% of all of the money spent on emergency care. And because of the increased focus on this cohort, there are a number of different initiatives currently going on, led by someone called Peter Greengross, who is both a public health and an A&E colleague based at Imperial. Looking at some local residents' data in Hounslow, in the 12 months to date, we had about 1,300 residents who accounted for nearly 7,000 hospital attendances, and most of those were to West Middlesex Hospital. But it also was to across all age bands, and around 10% of those were individuals who had a recorded diagnosis of severe and enduring mental illness, such as schizophrenia or a learning disability. And I've put some information in the pack that shows how Hounslow compares to some of our neighbouring boroughs in Northwest London. So this was really just to signal to this board some of the work that's currently going on. In order to tackle this, we are establishing a new team, and that team will combine a high-intensity user care coordinator based in the community, a caseworker based in the emergency department, clinical leads in emergency medicine, clinical leads in community and mental health teams, and together these core teams linking with drug and alcohol services, the ambulance service, voluntary sector, etc. We will be working to proactively identify and care plan all of these individuals with their consent in order to support their use of emergency care and better meet their needs more definitively. I've had an update from Tom, who's leading on behalf of the emergency department at Westmead just today, that said that in the last week, all of these roles have now been recruited to, with the exception of a new consultant who starts in December, who will become the clinical lead. And there's a very high level diagram of what they're hoping to do in the pack, which effectively illustrates regular case finding, care planning and coordination, and providing coordinated care support on a regular basis to those individuals. And their plan is to continue working with the neighbourhood teams, including primary care and colleagues, to continue supporting these individuals. Two other brief additions that aren't included in the report are just to acknowledge some of the joint work that's happening in the borough-based partnership around this population. So in addition to that, which I've just described, we've got work linking with the council's community solutions team, with a community solutions caseworker providing supplementary discharge support for individuals who are frequent users of emergency services, and that's going to be linked with additional support for floating support within the council. And that practical support, I think, is trying to identify some of the kind of social drivers for individuals accessing healthcare. And in addition, West Middlesex is continuing to work with the voluntary sector, and they have a British Red Cross service that is also supporting individuals to be discharged from hospital with enhanced support for a 6-week period after admission. And I think there is an aspiration to continue linking with the hospital social work team, as well as the social workers in the localities, to contribute to the care coordination that these individuals will receive. So I really just wanted to provide the board with an update based on that area of interest that was highlighted in previous meetings, but also to offer a promise, probably not from me, but from some of these individuals in this team, to come and provide some further information as the project continues.
Thank you. Thank you, Chris. That was really interesting. I was just looking at the chart actually, which shows the numbers. I was trying to work out. Obviously, we are high, but are we the highest or?
I think I'd need to do some. I think I'd need to do some maths to work out the rates by population, but we're not.
We're high.
Yeah.
Yeah. Okay. And I just it's good to see all the work going on. You mentioned community solutions, etc. That's brilliant to see. But I was just a little bit puzzled because in terms of, obviously, we have talked about this before. I've been in meetings where we've discussed this quite a lot, but in your findings, you've got that clinical complexity with high levels of unmet need. Was that medical needs you're referring to not being met, or just are there social, economic sort of factors there as well?
Definitely both. Definitely both. And in fact, it would also link to the conversation we had earlier about stability of housing and all kinds of other both psychological, social, and medical factors.
Yeah, I think just to kind of look at the high numbers in the other populations are kind of higher, bigger populations, so the denominators, yeah, bigger. I suppose just with regards to the diagram that you've got, Chris, this is personal view, is that often I think that we in the NHS and local authority feel that we have to rescue everybody in that kind of social space. And I just wonder how much we mobilise the voluntary community sector, because actually some part of this feels a little bit sort of loneliness, social isolation, as well as that kind of social capital, the feel to be included. And I wonder whether and it's a little bit of a mantra at mine at the moment, is that having sort of looked at sort of priorities across places, how are we assessing the ability of these people to be joiners? Those people that feel able to participate in neighbourhoods and communities, sort of groups that the voluntary community sector have established, rather than a kind of a statutory organisation approach, where I think people tend to come because there is a kind of officiousness about it, but actually in terms of sustainability, it's a bit like this is a bit of a prompt. Netflix have got a really good documentary on Join or Die. It's a kind of a look at Robert Putnam's work on social inclusion and joiners and what the health benefit of that is. But I suppose for this particular group, the question is, are they able to participate? And how do we move them to a position where they could get the benefit from that if they're not already? So it's a bit, so I'm prompting that, honestly, that was a revolution. I've read the book Bowling Alone, which Robert Putnam wrote, but actually that documentary was just kind of like, yeah, that we've got to get that right, that neighbourhoods and communities work.
Other streaming services are available.
Yes, yeah.
I completely agree with you, Kelly. I suppose that one of the hypotheses, and I will feed that back to the colleagues that are doing the work here, one of the hypotheses is that high intensity use of emergency care services, and that includes phoning ambulances, dialing 999, perhaps unscheduled use of primary care, as well as attending the emergency departments, is using statutory kind of very kind of NHS-y functions in a way that might ultimately not be meeting their needs, and is also driving cost and challenge and pressure within the systems. In a previous model that we've done in another borough, we spend a lot of time using tools like measuring the patient's level of activation, using validated tools, the patient activation measure as an example. And then for those patients who had a degree of activation, who were able to, with education, provide or make other choices, we could merely provide education and they would make other choices. But for a group that had low levels of activation, we then needed to make an activating intervention, such as motivational interviewing, etc., and often a kind of psychological based approach to both educate and support. And I think the other piece of work that we've often found that is necessary is to support the activated community around some of these patients, to ensure that they don't unhelpfully reinforce unhelpful pathways. And I'll give you a really good example of that. We had an individual who had really significant anxiety associated with a known breathing difficulty. So because they felt breathless, they would become anxious about feeling breathless, which would make them feel more breathless, which they would think was a relapse of their lung difficulties, and they would call ambulance services and end up in hospital, where things would inevitably settle. So the reinforced behavior there is, when I feel breathless, go to hospital and it will make me feel better. But in fact, one of the hypotheses was some of this was also being driven by the comorbid anxiety. Now, unless we have the right support for instance, our talking therapies teams, if a patient with a known lung disease becomes extremely breathless in an anxiety session, there is a danger that the therapist will call the ambulance. And that's exactly the wrong thing to do in this circumstance. So that's partly why we also need to support community and voluntary sector to make sure that safe decisions are being made, but also we're not unhelpfully reinforcing the behaviours.
Thank you for that. Any questions? Oh, sorry, Stephen, you had your hand up. Yeah, thank you.
So this is interesting. I think the bit that interests me most, and all of it interests me, but the bit that interests me most of all, certainly from the 2017 cohort, was the frailty population, which is 17%. I'd lay money that that percentage would be much higher. Here we are in 2024. So I think so in the absence of the clinical lead consultant, presumably the care coordinator is your trust employee. So I think we need to bring that person into the discharge brackets admission avoidance discussions we're having, because we did a MAID event some months ago about readmitters to West Mids, and 2 of those individuals were classic high intensity users. Interesting you said about breathing and anxious, because one of them was COPD, smoker, oxygen saturation dips, son phones GP phones London Ambulance Service. She gets admitted to West Mids because saturation levels are low. She's there for 3 or 4 days. She's back out for 6 weeks, and surprise, surprise, back again. Of course, we can't provide her with that treatment in the community because she's got cigarettes and matches at home. But I did jokingly say, so could we not send a van to sit outside for 3 hours and just get our oxygen saturation up? So I think we do need to look at probably the frailty cohort slightly differently, given the pathways we've got. So there's a new frailty ward at West Mids. We've got the home at hospital. We've got the bridging arrangements. We've got ICRS. I think we could tackle that lot through that conversation, because I think there is, for me, a bit of a separation between the frailty cohort and those who have got a mental health diagnosis, learning disability, or something to do with anxiety. Not that those people won't have that, but I think we should try and tackle that through the frailty work.
Couldn't agree more. And I think that this really nicely links to some of the frailty work the Borough-Based Partnership wants to do more broadly, and with kind of other initiatives, including dying in your preferred place of death and anticipatory care planning and all kinds of other planning initiatives for which we've got the tools, but we need to ensure we've got the processes to make use of them.
So if you can drop me the name of the colleague who's the coordinator, we'll invite them into the next meeting we've got for a conversation, I think, Chris.
Okay, thank you, Stephen. If that is noted, then thank you. Dr. Gupta?
Yeah, so agree with Chris, agree with Stephen. We are starting to form a task and finish group around frailty. And we are looking at care homes. We're assembling the same group of people that I think will address Stephen's concerns here. So if it's okay, Stephen, I'll reach out to you outside of this meeting to assure you the work that we're doing and get the right people on board.
Thank you. It's good to hear. Can I just, following on from that discussion around frailty, how are we using our social prescribers? How well are they being used? Because obviously, if you've got older people going into GPs quite a lot, it may be that they're worried about a number of things, but which could be dealt with probably outside. I'm just wondering whether that is working okay. I know they are operating, but I'm just not sure what the outcomes of that is.
I think if you challenge me to provide firm outcomes on that, I would struggle to do that. In terms of access to social prescribing, our frail population have got two routes, and they can go in through the council or they can go in through their primary care service. So there's good accessibility, and we are promoting those services. But I'll probably have to take the query around outcomes from the social prescribing the frail population away and work with partners to see how we can answer that question.
Thank you. Thank you very much. Thank you. I don't think we've got any more questions, but that's just for noting. Obviously, we're noting the work that you're going to continue to do in the future. Thank you. In that case, we will then move on to the next agenda item, which I think is you again, isn't it, Chris? Yep. and it's it's an update on the mental health work that you're doing with Health Watch. Yes.
Yes, and again, this is a lesson for me about making suggestions to the board because they often turn into action. So this was an offer that we made, an observation from attending health and wellbeing boards with Health Watch colleagues for the last 2 or 3 years in all 3 of the boroughs that West London serves, is that the feedback that comes often from the statutory work that Health Watch does often doesn't pick up feedback from mental health populations. In the trust, we often struggle to get robust feedback from our populations, often because we're treating people at a moment of significant crisis, or because we are using slightly blunt instruments like the friends and family test. Would you recommend us to your friends and family? That generates data, but actually the richness of that data and our ability to respond to it is often a bit blunt. So a couple of years ago, West London Trust began working with Health Watch across the 3 boroughs that we support, and we got to put together a contract with Health Watch to actually ask them to help us to extract much more detailed qualitative feedback from the populations of patients who were using our inpatient mental health services. And we thought you might be interested to see what that said and what we're doing with it, which is the purpose of this report. Just for context, we're about, I think, about 18 months into, or over a year into the second year of this piece of work. And we've looked at individuals who are admitted in both of our mental health units for adults. So we've got a mental health unit at Charing Cross Hospital and a mental health unit at Lakeside next to West Middlesex. In total, we've got just over 150 adult mental health beds, and Lakeside is the larger of those 2 units with 89 beds in the unit. And typically, about 85% of Hounslow residents find themselves admitted in Hounslow to the Lakeside unit. So I think we'll share some generic feedback, but any references to Lakeside Mental Health Unit are, broadly speaking, applicable to Hounslow residents who access inpatient adult mental health services. And I think the way we thought we might do this is, after that brief introduction as to why we did it, I thought I might invite Ashla to talk about, from the Health Watch side, what they did and how they get this information. And then the presentation that we're going to put on the screen is a little bit of a "you said, we did" format. So we'll learn a little bit from what Health Watch elicited, and I will share a little bit of what the Trust has done with that information, if that's okay. So over to Ashla.
Thanks, Chris. So over the past 2 years, almost 3 years, Your Voice in Health and Social Care, via their service Health Watch Hammersmith and Fulham, has been delivering an inpatient engagement project, which has been led by Carlin Duffy, who is kindly with us today to answer any questions you may have, who is also the area manager for Health Watch Hammersmith and Fulham and Ealing. So most Hounslow residents are admitted to Lakeside Mental Health Unit on the West Middlesex side, but in the rare instances, some will be admitted to Hammersmith and Fulham Mental Health Unit at Charing Cross Hospital. The findings provided by Health Watch to the Trust includes the feedback from all residents of 3 boroughs, Ealing, Hounslow, and Hammersmith and Fulham, receiving treatment as these 2 units. The Health Watch project involves undertaking regular engagement with patients in the acute wards in the 2 West London NHS Trust mental health units that Chris just had mentioned, which is Hammersmith and Fulham Mental Health Unit at Charing Cross, 4 wards, and Lakeside Mental Health Unit on West Middlesex Hospital, 5 wards. Monthly visits are made to each individual ward at each unit. Engagement takes the form of one-on-one discussion with the patients, using a questionnaire as prompts to seek the responses on key issues and ensure some consistency. The questionnaires used is adapted slightly each month, following a review of the relevance and clarity of the questions asked in the previous visits. The project aims, basically, as part of this project, HealthWatch is using volunteers and experts by experience to undertake engagement and ensuring appropriate training, support, and debriefing for all those are involved. The project provides monthly update reports, several deep dive reports, and the potential for further annual comparative analysis. The report celebrates areas of good practice and highlights the potential areas for improvement. The report also provides a clear opportunities and potential actions for West London Trust to discuss internally and respond to the patient's feedback. Now, I'm briefly going to talk about the findings. Can we put it out? Oh, it's here. Okay. So the findings is from the data gathered by HealthWatch is from May 2022 to April 2024, which is produced by 8 teams. Engagement findings produced 17 patient recommendations and 16 HealthWatch recommendations in the Lakeside, and 13 patient recommendation and 15 HealthWatch recommendations in the Hammersmith and Fulham. Gained users' perspectives using one-on-one sessions, groups and experts by experienced volunteers by monthly engagement visits. A mobilization period between April to June 2022 in Hammersmith and Fulham Mental Health Unit and Lakeside Mental Health Unit, but the project has been extended to 2025. So the theme 1 was staffs, and overall patients felt positive about the attitudes and communication of the staffs, perceived as helpful, supportive, respectful, and caring. They wanting better communication between the clinical staff and the patients. Patients feel staff could respond to their requests more promptly and communicate delays. Nursing staffs could spend more one-on-one time with the patients to get to know them as a person. Feeling wards could be understaffed. Patients expressed a lack of understanding of different disorders by staffs. The second theme was patients are.
Shall I just we'll do them
Yeah, okay.
interchange if that's all right with you, Chair.
Yeah.
So in response to the feedback about the staff, obviously we were pleased that patients were generally positive about attitudes and communication, but there was a number of areas of specific recommendations about when staff were busy doing other tasks, how we communicated that with patients, and if there had been any delays responding to patient requests, the matrons, the ward managers are feeding that back in their daily safety huddles and making sure that they're communicating better with patients about the possibilities of delays. There was a question about wanting to know more kind of personally about the staff. Tell us a bit about yourself kind of thing. And so there are installed on every ward with a kind of getting to know you appropriate vignette about the individual colleagues that they may meet regularly. Of our staff have time ring-fenced to attend what are called community meetings with the ward community. So the inpatients and the staff will meet together and talk about how the ward is participating. Grosvenor Ward, which is one of our lakeside wards, I've put forward to a national programme called Improving the Culture of Care, and this is being led by the Royal College of Psychiatrists as a quality improvement programme, and any of the learning from that national programme will feed into learning across the unit. Obviously, there are pressures on our wards, and the sense that patients were feeding back that the wards could be understaffed was of concern. So we do illustrate on all of our wards, as you'd expect, the number of staff that are expected to be on shift and the number of staff that we have on shift. So we're monitoring our fill rates for all of the days, and that's reported in our board report. We have reviewed the staffing establishment on every ward across local services, and we have revised it upwards in order to ensure that we've got the appropriate number of staff to manage patients with complexity who need one-to-one care, and also to ensure we've got staff to support people going off the unit for garden breaks or supported leave or to attend ward rounds. I've submitted a bid to North West London ICB through a programme of service development funding called the Inpatient Quality Transformation Programme to pay for that staffing establishment uplift. And we've also responded to concerns about staff wanting more information, patients wanting more information about their care by having information leaflets about all mental health conditions on all of the wards. I'll let you carry on with your other themes.
Chris. The second theme was facilities and surroundings. So patients are mostly satisfied with the cleanliness of the wards and access to the facilities such as gym and garden. Mixed satisfaction with the good regard mixed satisfaction with the food regarding nutritional values and freshness, some dissatisfaction with the limited variety of alternative dietary preferences, including allergies, intolerances, vegetarianism, or veganism. Patients are mostly satisfied with the cleanliness of the ward, although many felt that bathrooms and shower rooms should be cleaned more frequently. Frustrations around phones, charging mobiles, access to staff room phones, and payphone broken. Patients don't always have personal access to a safe place to put their belongings, so they want some space, personal space to put their belongings. Over to you, Chris.
Thanks. I'll be brief if I can, but just to give you a sense that we've responded to all of these areas of recommendation, including working with our catering subcontractor and asking patients to help co-produce some of the menus. There were questions about the availability of sanitary products, and we've put information about how we can support that in our admission packs. A whole series of actions around making sure that each ward has a dedicated domestic staff member and the supervisor supporting the cleaning. We have a program of work called the Patient-Led Assessment of the Care Environment, which is a joint audit of cleanliness and safety on our wards, which is reported to the board every year. And we're putting individual lockers across the wards so that patients can securely place their belongings there, and all patients have a key for their bedrooms which can be locked to help keep their items safe. There was one other piece of feedback. I think the patients were a little bit unhappy with some of the bedding, and we haven't been able to address some of the bedding challenges entirely because of health and safety, fire regulations, and infection prevention and control requirements, but we have made extra blankets available.
Thanks, Krish. The third theme was treatment and care. Most patients are aware of their diagnosis but can be unsure retreatment and discharge plans. Patients shared concerns regarding uncertainties and lack of communication around their treatment plan and updates, what needed to change to get to discharge. Patients expressed wanting their families to be more involved in their care, especially during the meetings, as it reassures them to have like trusted second pair of eyes and ears. Patients could feel unsafe due to potential conflicts with other patients, especially when staffs are not present.
And again, I won't go through every one of these bullet points, but again, we wanted to respond to all of these factors and have tried to carve out specific time for named nurses to help work with patients to understand all of their concerns and to co-produce their care plans. We are engaging in a program of work called the Triangle of Care across the Trust, where the third part of the triangle, as well as the clinicians and the patient, is the carer, to better involve carers at all stages of admission. We are trying to encourage our community teams to continue ongoing input to patients throughout admissions, particularly to prepare for discharge. We've put specific information on the wards around other aspects of treatment, including time to meet with the ward pharmacists.
The fourth theme was around information and support. Patients stated that there is an over-reliance on medication to get better and that there is not enough opportunity to speak to someone about their mental health. Currently, many patients don't have access to or are not aware of available talking therapies. Patients said that community meetings either don't happen or they feel rushed. Patients also commented on not being told or forgetting information shared on mental health rights and advocacy services, complaints procedures and activities, and limited access to or awareness of a suitable space to practice their religion or cultural practice.
Thanks. And of course, responding to all of these, we are working with our psychology leads to make sure that we've got specific structured therapy sessions available on all of the wards to address some of the concerns about psychological approaches to treatment. That links to the work around culture of care and the inpatient quality transformation. We've developed an admission pack and a whole range of information on notice boards about rights and advocacy. We do regularly audit that patients are given their legal rights, and that is documented and auditable. But at times of significant distress, patients often don't remember. So repeating that and making sure the information's available on the ward in other formats and other languages is obviously important. And finally, there is a multi-faith room available to all of the wards and chaplaincy services, and that's been added to the information pack that patients are given on admission.
Thank you. The fifth thing was around activities. Some patients expressed a desire to have more fresh air or to do more outdoor recreational activities. Women in Finch and Robin wards mentioned that they would like to have more self care sessions like hair and beauty salon sessions. Patients stated the need for more occupational therapy activities and how beneficial these were. Patients would like more opportunities to learn life skills to stimulate their mind and other recreational activities involving music.
Thanks, and you rightly spot a theme here. I mean, this is intended to be, the patients have told us, so we're trying to respond. There is an interesting thematic link between the earlier presentation about smoking cessation and the desire of some of our patients to have fresh air. We do interpret that as a request for fresh air, but it's worth this committee noting that we also provide nicotine replacement therapy and support and encouragement even to patients in a mental health crisis to make healthier lifestyle choices. We've had some challenges with the garden at Lakeside due to some safety issues with the guttering, and I'm expecting that'll be reopened very shortly. And I was pleased to learn that we have a salon at Lakeside for our female patients to access on the women's wards, which I'm hoping will help address the queries about self-care sessions.
Thank you. The sixth thing was around medications. Many patients are content about their medications and stated that they are always notified of changes in their medications and complaints of side effects are responded to. Patients sometimes forget about doctors' explanation of changes in their medications. Seeing changes in the medications without remembering the explanation can make patients uncomfortable. Communicate with the doctors was sometimes felt to be difficult.
And again, we've tried to spend more time ensuring that we are explaining the treatments that are being prescribed in this circumstance. But we've also got written information on all of the wards, and I'm happy to advertise to anyone who's interested the Choice and Medication website, which provides information about all range of mental health medications in a whole range of languages, but also in an easy read format and languages designed for children and young people, etc. as well.
Thank you. The seventh theme was around continuity and integration of care. Some patients express they have regular contact and feel supported by their care coordinator, while many patients felt they are not in contact with community care coordinators, and this led to some sort of anxiety around housing, work, benefits, and aftercare. Patients reported not receiving information and support before their last discharge. Patients also reported a lack of personalized discharge care plans to address work, benefits, communicating with social networks.
Thanks. And as the Chief Operating Officer of the Trust, observing the flow through our services and the rates of readmission that we have in our services, this patient information triangulates well with some of the concerns we have about the integration of pathways within West London Trust. So we're trying to put robust processes in place to make sure that once a patient is admitted in a crisis, they aren't seen as, oh, I don't need to think about them anymore, by the community team that continues to be their source of support on an ongoing basis. So we've put in improved notifications to make sure that community teams know that patients have been admitted. We've got expectations now around liaison and inreach from the community onto the wards to support admission planning, transfer of information, ongoing support, and discharge planning from the point of admission. And that applies both to community health staff, but also links with social care services.
Thank you. The eighth theme was dignity and respect. Predominantly, patients feel well respected and taken seriously by the staffs. Main negative sentiments center around our lack of confidentiality. A number of patients said that some conversation with the staff should be more private. Patient expressed feeling stuck inside and having their personal freedom compromised. This anxiety is often exacerbated by not being able to smoke.
And of course, we want to provide dignified and respectful care to all of the patients. And some of this links to the liberties that are inevitably restricted for patients. The majority of our patients who are admitted are under the Mental Health Act, and therefore there is a complex negotiation around agreed, escorted, and ultimately unescorted leave within the scope of the Mental Health Act. the way we're addressing some of these things, of course, we have private spaces and are reminding staff that they must use them for confidential conversations, and patients must consent to having student nurses and student doctors listening in, although we encourage them to consent so that they can be part of those individuals' learning experiences. I think this is about an ongoing aspect of ensuring that we're providing dignified care on our wards, and this, you'll be pleased to know, is the final theme. And really the summary from the perspective of the trust was how grateful we are to have worked with Healthwatch. It's handy that Healthwatch Hounslow and Healthwatch Hammersmith and Fulham are buddies in a bigger organization, so they could do this work for us across our patch. This does not replace the ability of Healthwatch to make enter and view visits. It does not replace our responsibility for providing patients with statutory advocacy services and also collecting our own feedback directly. But we did want to supplement that. And you can hear that over 2 or 3 years, the work that Carlene's been doing, we've got about 400 people spoken to, which is a significant proportion of the people that we would have admitted over that time. And all of this data, I know, is going to ward managers, to matrons, and is helping us to think about stuff that, some of it's not rocket science, to be honest, but it helps us to understand what patients are saying. And there is a lot of nice things said as well in the appendices, which is also nice to hear at a time when our staff are feeling particularly under the cosh. But thank you.
Thank you. Yeah, thank you for doing a bit of a double act there. Thank you. That's really helpful. I was as you quite rightly said, there's a lot of things in there that are not rocket science. So I was a bit surprised at some of the recommendations that they weren't already taking place. So, for example, pictures of staff and stuff like that, and names, which I find quite routine in places now. So, I mean, it's good to see the service sort of updates that you've made as a result. But just a couple of things that I kind of came to mind as I was listening to that is firstly around, I know obviously you've been listening to patients and you'll continue to do that, which is really good, and hence the improvements as a result. But I wondered how much, and I think you touched on it, you're listening to carers, because obviously when patients are very unwell, they're going to be relying on their family and carers to actually speak for them. So I know this is from patients, but have you done something similar to carers? Listening to carers, that would be interesting. And also something about care coordinators. I don't have a lot to do with them in my work as an elected member, but I have occasionally come across constituents with care coordinators, and I think there seems to be a theme about not really getting the service that they'd expected, which I suppose at times has worried me, because these are people that are kind of on the cusp of possibly needing to go back into hospital because they're just not getting that support that they need around housing, rent, benefits, all that kind of stuff. So I just wanted to pick that. I hope that can be sort of looked at and improved. Yeah.
I'll just make 2 very quick responses to that. So on the carers piece, this project didn't specifically focus on carers, although I'm sure Carlene is probably thinking maybe we could pitch to do that work together as well. And that's a conversation we can have. We do have a strategy in the trust around learning from and engaging with carers as part of that Triangle of Care program that's sponsored by the Carers Trust. And we have a Carers Council, which we encourage regular individuals who are involved in providing care to individuals that we look after also to attend and provide feedback. And we do have a carer representative on our quality committee who feeds some of that back as well. But I take the point, and we'll certainly feed it back into the trust. On the care coordinator feedback, I think that's a known issue, and we've got some work that I'm leading at the moment in our community mental health teams. We did a piece of work about 3 or 4 years ago that was kicked off by my predecessor to transform our community mental health services along the lines of a new national specification called the Community Mental Health Framework for Adults and Older Adults, designed by the Royal College of Psychiatrists. And it has really fantastic aspirations around neighbourhood mental health teams that are really accessible and easy to access. One of the negative sides of the transformation work that I've perceived is that we now have extremely large and much larger than forecast caseloads in some of our community mental health teams. And within those caseloads, it was challenging in the new model to differentiate between those who have common mental health problems like anxiety and depression and the most complex patients who find themselves perhaps with schizophrenia or bipolar disorder being admitted in crisis to the mental health unit, the patients that Carleen and her colleagues have met. What I've asked the teams to do over the last few months, and it's on track to be finished by the end of October, is to segment all of those caseloads into sort of crudely defined routine patients in secondary care, and then a more complex cohort of patients. And that complex cohort of patients are the ones that we need to ensure we are seeing very regularly, much more assertively, and providing prevention of readmission, secondary prevention services. So that's the ongoing work we're doing on the community transformation.
Thank you. That's good to hear. Thank you. Sorry, I didn't catch your names.
Carleen.
Carleen, hi.
Yeah, I was actually just going to mention that we are also doing, we've got carers groups in both sites. And over the last 6 weeks and over the next 3, we do a themed week with the carers every week where they can come and learn. So today's one was, I think it was mental health rights, and last week's was medication. And then I think I'm on the last week presenting, discussing, sort of collecting service users' feedback. So yeah, Chris has already got me working for free and he doesn't know. So
It's really good to hear. Any other questions? Can we just note the really good work that has been done actually, and some very interesting engagement there and findings. Thank you very much. Okay, so we will now move on to the next item, which is the Better Care Fund. And Martin is not here, but this is, as you know, sorry? I know, I will bring it. She's rushing me. No. I have a plan, Callie. I have a plan. So obviously this is something that we sign off at the board regularly from time to time. Martin is not here. I'm sure you would have read the paperwork associated with this. It can be quite complex, but so we're not going to go through it unless Stephen has something particular that you want to share or to present. Yep.
So just to make sure we close the loop. So as you say, Councillor Bath, the Health and Wellbeing Board has oversight of both the Better Care Plan submission for planning and the Better Care Plan regular quarterly monitoring. This is a submission to the Better Care National Team for Q1 of this financial year. This time they have only required us to report on the discharge fund, which was formerly known as the Adult Social Care Discharge Fund, which is 60% of that money flows through the ICB, 40% comes direct to the local authority, and on the 60% we have to agree with our ICB colleagues as to how that money will be spent. So all we're reporting here is on the discharge fund, not the remainder of the BCF, which is about £22 million. So all I would bring your attention to is, and I'm looking at the electronic version of the pack here, is the third document titled Better Care Fund 24-25 Q1 Reporting, which is a table which has a list of schemes. Down one side is shaded slightly blue across the middle, and has a commentary box at the right-hand side. Those are the schemes within the discharge fund, and that's the up-to-date position on where we're at with projected spend and those schemes. And I would say to the Health and Wellbeing Board to be assured that everything is being spent according to the Section 75. But delighted to take any detailed questions if anybody's got them on the spend or the schemes. But subject to that, Health and Wellbeing Board to approve the Q1 submission.
Thank you. So are you happy to approve what you've seen? Are you reassured that you're yep. Okay. Okay, in that case, there's no further questions, then so we move that we will accept we'll sign it off rather. That's what I'm looking for. Okay, thank you. Then moving on to the next item on the agenda, and that is the health and wellbeing strategy. And I've got Kelly, and it's only, I think Kelly's assumed you would have read it. So it's just really to pick up anything that you've read and you want to flag up. Over to you, Kelly.
Yeah, I'm taking it as read. We at the last meeting we agreed that Modesta and Pauline and Vivana would come because those are the those are the red rated ragged area. I'm sure there's a combination of those words that follows some kind of sequence. I suppose the question is for us as a board. There's one red, which is what we discussed today. There's a number of amber. What would we like to oversee at the next meeting in terms of providing some assurance that action's taking place? If there are any recommendations, then please let me know. If not, I can make some recommendations for you, but I'd like to sort of hear what colleagues said first.
Anybody who's read that, is there anything in particular that you think we should be focusing on?
I think, Councillor Bath, my view would be we would take Kelly's recommendations in the amber area to anything that she would consider would be worthy of us turning our attention to in terms of assuring delivery. So there's a lot in the amber. So which of the ambers is the one that we really need to have a bit of an oversight of?
So I think that the drug and alcohol work probably needs to come here. So Stephen, you chair the Combating Drug and Alcohol Partnership Board. We're in the third year of the National Fund, third and final year of the 10-year strategy national funding. We only got funding for 3 years. There's a drug and alcohol retender that's going on. We've picked up from Modesta and Pauline today some really key issues in relation to drug and alcohol services and homeless and rough sleepers. I also am aware that the drug-related deaths panel has started. And I think that there is an opportunity to think about how is that brought together in a kind of big picture way rather than sort of having parallel lines. I think the other 2 areas that I would suggest is it would be really good to have a picture of children because some of those indicators have not moved. And I think the third area, which I would suggest, which is kind of aligned to but a little bit separate from, is the next meeting's in January. The annual public health report would have been published by that. That is focusing on the core 20 plus areas of the NHS strategy / the EDI work for the borough. That will pick up some of the equalities and make some recommendations about how we move forward, which aligns quite nicely to moving into year 3 of this report, of this 3-year cycle of activity. So we can do all 3, we can do 2. I would suggest there's at least 2 there, but feel free to challenge that.
Thank you, Kelly. So Kelly's given us a list of those that she thinks we could focus on. I'm assuming that everybody is happy with that. Should we go ahead with that? Yeah? Okay. All right. Thank you. Stephen. So do you want to prioritise the ones that we've identified as needing work on? So yeah, children, is that what we're saying? Yeah.
I think what I'm saying, I think, Stephen, we're saying children. Do you think that we should be focused on drug and alcohol because of that kind of timeliness?
Children's drug and alcohol, so purely just on agenda planning time-wise, children's drug and alcohol.
And then the core 20 stuff, because that would be the annual public. Right, okay, so we can do that in an hour. Yeah, perfect.
Okay, any other questions on that? No. Okay, thank you very much, Kelly. And then we will move on to the next item. I think we've got a couple, we've got one more left, which is a joint strategic needs update. And again, that's you, Kelly. It's just, sorry. Yes, I've got it completely wrong. How are you? All right. I did see you coming. All right, over to you.
Thank you, Councillor Bath, and my apologies for the late arrival. I was double booked. And I am not Suk. I'm a poor replacement for Suk, our JSNA Programme Delivery Manager. Suk works in my team. I'm Sarah Philby, Director of Strategy, Performance and Commissioning. Still doesn't roll off the tongue. So I understand at the last meeting you had a far fuller update. So I'm just giving a quick verbal overview of the work of the team and flagging the connections to some of the other agenda items and potential work for the board to look at in the future. So 2 new products on the data hub this period, which both speak to Bhavana's update earlier on the agenda, a smoking cessation report and a snapshot looking at smoking and vaping in young people. Those reports and the work that sits behind them will be used to inform the tobacco control plan, etc., etc. Bhavana's already spoken to you about that, so I won't say anything more there. I think also worth flagging, the wider team is supporting our housing, homelessness and rough sleeping strategy. So the needs assessment for that is well underway, and the team will continue to focus on that and supporting colleagues in housing with engagement, both internally, but then with partners. And subject to that work, we may well want to bring something here at a future meeting. But I missed Pauline's update, so I may be cutting across what she's already said there as well. I should also flag the work of the team on the pharmaceutical needs assessment, which has just kicked off, and winter readiness. So a bit of a tried and tested approach now. We've done it for a few years. We interrogate local health data to support effective vaccine take-up and targeting through the fantastic work of our public health outreach team. So we've done that again. We've looked at more detail at winter fuel payments and socioeconomic, just a slightly different slant on that given the changes nationally, and are trying to work with Revs and Ben's colleagues to inform their wider support offer. So lots of stuff there which is sort of outside the realms of health activity, but that broader wellness agenda. Some other products that colleagues might be interested in looking at, oh no, actually, sorry, this is an update from the last meeting. Suk took you through the Hounslow VCSE dashboard, I think, last time you met. And there was a particular question around the reach of that. He's done some delving into Google Analytics, and I can tell you that we've had just under 500 page visits since that's been live. And Suk and the team are working with colleagues in our new sort of resident experience localities team to think about how we can make better use of that, and shared some data with some public health colleagues just this week on that. Also updated products on there on CQC provider ratings. We've updated, and Stephen, you'll probably be interested in this, our adults and older people population needs projections again, feeding into finance colleagues, etc. And we've got a new look Hounslow market position statement on there, just making that a bit more live and dynamic using the Esri product. So those are all the things I was going to flag. Happy to take questions, but yeah, it's just a quick verbal update from me.
Thank you, Sarah. I'm sorry for missing you earlier. Any questions, Stephen?
So I didn't raise it because we were having the conversation about smoking cessation, but I think Sarah's raised it now, which is the incidence of vaping in younger people, because I make a gross assumption it's not based on evidence, and I might be proved wrong, and that's fine, but it is almost the first go nowadays for young people to go to vaping rather than smoking. So I think, as Kelly said, vaping is great to get people off smoking, but actually as a first step into a substance, it's not a great thing for 13 and 14-year-olds to be going down into. So I think it would be maybe useful to see that in detail here next time back and consider how that does actually link, if that's the right words, with the smoking cessation, because I think we need to have a double-pronged approach. And it has come up in our Children's Safeguarding Board. It's not appropriate because it's not a safeguarding matter, but I think there is enough concern to say we need to be aware of what's going on in our community for our young people about vaping, because it's not a healthy option. It's a healthier option if compared to smoking potentially, but it's not a healthy option. So maybe next time we need to have a look at that in detail, I think. And whether or not for the refresh of the health and wellbeing strategy it becomes a line in its own right if we consider there's enough evidence in there that it's not a great position.
Thank you, Stephen. I would definitely echo that. I mean, I think it's about getting the messaging right, that it's not a healthy alternative, because it still is, isn't it, considered, and which is wrong. And you're right, it's the very young age group that is quite concerning. Yeah. So sorry, did you want to respond to that, Sarah?
No, I was just going to say, I think we would need to do further work on that, because the product we have is a snapshot, and I think actually the absence of data is a bit of an issue there. So I think we can certainly, working with Bhavana as the subject matter expert, think about the nature of the work we need to do to bring back something meaningful to this group. But I'll take that away and pick that up with the team.
The other dimension we need to tie into that is with enforcement colleagues, because we'll have all seen reports in the press about the content and the origin of some of these vapes that are easily made available. So I think we need to get a sense of, are we seeing that trend in Hounslow in terms of supply of illegal or unregulated and dangerous vapes that are finding their way into our community. So probably a snapshot doesn't even cover that, and that's because it's a snapshot. But I think we need to get some sense from enforcement colleagues what we're looking at here.
Yeah, definitely agree with that. Is that something that you'll be doing as part of next stage?
We'd certainly look to engage with colleagues across the organisation, but we will make doubly sure that that happens. Yeah.
I think that is the end of the meeting. I have had no other business raised with me. Oh, I do now. Yep, Kelly.
Sorry, Councillor Bath, just prompted by what Sarah said and I suppose what Stephen said as well. I've taken the liberty to start the PNA, the Pharmaceutical Needs Assessment. Just a reminder that it's a statutory responsibility of the board to produce one of those every 3 years. Public Health are responsible for delivering it for the NHS, bit of a legacy of a core offer when we were in the NHS. So Anne and I have commissioned Soar Beyond. They are the organisation that has done our PNA for the last, this is the third time. It is a program of activity with high fidelity, so we have to follow quite a strict rule about how we do it. There's a lot of consultation with the public. The current consultation in the early stages is currently live at the moment, and we have to publish by the end before the 1st of October this year. So we'll bring it back. It has to be signed off. We're aiming to bring it back to the board by July, which gives us quite a nice period to sort of sign it off or make any amendments. If you remember last year, we were signing it off, I think 48 hours beforehand. Not last year, 3 years ago. Doesn't time fly? You know, I did take the liberty. If you can just confirm you're happy with that liberty, that would be great. That's number one. I'm just taking that everybody's okay with that as a kind of shrug. It's okay. And the health and wellbeing strategy. In advance, we've still got a year of the strategy to go, but time will catch up with us. So one of the comments that Councillor Bath, you've mentioned and Stephen's mentioned in the round is about that kind of 3-year fixed term period and how we can be a little bit more dynamic with that kind of perhaps consider a rolling period of time. But what I would like us to consider as a board and to perhaps bring back to the next meeting and is a timeline for the next strategy, so that we don't get caught out on other issues that might sidetrack us, because this strategy will need an evaluation and a closing report, and for us to understand all of the new emerging issues that we might want to consider putting in the strategy, and how we make some of these areas business as usual, but some of them may well need ongoing oversight. So rather focus on fewer areas, but actually think about some of these areas may not be finished as our priority areas. So I think, well, if we factor that into the consultation of how we'll do it, just want us all to be in agreement that it's okay to start kicking off that early stage of the process.
Thank you, Kelly. That's very helpful. So I'm assuming we all agree. So there's 2 bits here: the pharmaceutical needs assessment, which Kelly has already started. Thank you for that. And of course, the health and wellbeing strategy, which again, need to start thinking about that early. I'm assuming we're all okay with that. Excellent. Okay. Thank you very much. In that case, I'll just remind you that the date of the next meeting, it's not until the 29th of January at 4 o'clock. So yeah.
Happy New Year.
Yeah, Merry Christmas. We can say that now, can't we? Seems a bit early, but anyhow. Anyway, yeah, and we finished on time. So I just want to thank you, everybody, for attending and obviously for contributing, and for those that might have joined online as well. Thank you very much. I'm happy to close the meeting now.